Yeah, thank you very much for the nice introduction, and I'm very happy to be here together with my wife, and I'm also happy to meet all my friends. We are long-term friends, Julian Che and MJ and Idong Ho, so we are actually meeting every year, I would say, on a lot of meetings, and I'm very happy to be here. For over 20 years now, I'm coming to Korea every year, more or less. And as you have heard, I do quite a bit of work in the IOL business, of course. The David Apple Laboratory, the main core focus is intraocular lenses. We test all the lenses from the companies, even before they come on the market. They come to us, show us the lenses, we evaluate, we tell them, this is good, this is bad, others are better, or yours are better, stuff like this. And then they decide to come on the market. So we go through a lot of testing, and then we do clinical studies for them, like we also did here for the Hanita lens, randomized prospective trials, where we objectively try to evaluate them and compare them with gold standard or with whatever gold standard is nowadays. But of course, the big companies like PanOptix from Alcon or other lenses are then the competitive lenses we're comparing it with. And we see if this lens is as good or even better as these established lenses. So in Europe, we have so many lenses. Yeah, not all of them are available in Asia Pacific in general or in Korea specific. And now it has shifted from, we have the monofocal plus or enhanced monofocals, which is a huge group now, and it's getting a lot of attention because on the one hand, they give a little bit of depth of focus, not much, but you can still use them to play a little bit in these patients. Let's go back, sorry about that. You can play a little bit with that to help them, and they are much cheaper than the trifocals, of course, because they are monofocals. Yeah. Then we have a group in between, the EDOF IOLs, and the EDOF IOLs were born to have a lens that can see in all distances, but still doesn't have, for example, rings or doesn't have any issues with dysphotopsia. However, a lot of the very first EDOF lenses were diffractive lenses, and they had some issues. But there's a lot of different type of lenses now. And then the trifocal group is actually the best defined group, yeah, because everybody knows what a trifocal is. Funny thing is, a lot of them are not trifocal. They are pentafocal lenses, they are bifocal lenses with EDOF parts, they are hybrid lenses, but they are all called trifocal lenses because clinically they give you intermediate, they give you distance, and they give you near. That's why they're called trifocal, even though the technology is sometimes very different. So we have these three groups, and they are kind of overlapping. If you look, for example, enhanced monofocals, EDOF, they are pretty okay in terms of quality of vision, and also people who are driving a lot. And this refers more to the American standards, because in the US, nobody walks. They all go with a car somewhere. Yeah, and maybe it's different in Seoul, where you hardly can use your car because you're sitting in the traffic jam all the time. And there's a difference between Asia Pacific and Western countries, really, I have to say that. Yeah. And then if you really want to have spectacle independence, then you cannot go without trifocal lenses. Yeah, you need that, and especially if you have a myopic population. Yeah, Asian population, for example, they need good near acuity. They are used to have pretty close. If I have a Nordic German person, almost 2 meters high, long arms, they don't read in 20 centimeters. Yeah, like a Viking. Yeah, they don't do that. But Asia Pacific, it's very important to look in the near. Yeah, so trifocal lenses are very important in that area. So for a long time, we had like 1 or 2 type of lenses. And we were looking, what is the right patient for these premium lenses? But nowadays, we have so many different lenses, and the question is, what is the right lens for the individual patient? So we move from to kind of personalized medicine, even in IOL selection. And we have nowadays also diagnostic tools to really look at the patient, look at spherical aberrations, corneal astigmatism, all kinds of stuff, where we can say, okay, this lens would be better than this lens. So we're living in a different world compared to like 10 years ago or 20 years ago. There are a couple of parameters, medical conditions, if you do cataract surgery or presbyopic lens exchange, if they are myopic or have astigmatism. Also, if they have certain preferences where they want to perform very good, yeah, and or the profession, which can also have an impact on the IOL selection, or the personality in a way, because you have to be careful. If the lens is too fancy and the patient is too crazy, you will have a lot of problems. Yeah, so you don't want that. And nowadays, the patients are very demanding. Yeah, they were happy when they didn't have any spectacles in former times. Nowadays, they want to have perfect vision. They pay for it, or they want to have the perfect outcome, which is not always easy to do. So trifocal lenses have evolved, become more and more and more. And based on the first introduction, like Artelisa 3 from Zeiss or Panoptics, which were developed early 2000, yeah, they are now almost 20 years old, 15 years old on the market. So we learn from these lenses, what is good, what is bad. And then companies look at it and how can we make it better? How can we get more light in the system? Because trifocal lenses usually lose 10, 15% of light because they chop the light in different areas. And so here's, for example, the Hanita lens, which really used a special algorithm to develop a lens where they take more usage of the incoming light. So the loss of light is much less. What they did actually is they were calculating the way how you do the rings and how you diffract the incoming light with an artificial intelligence algorithm, which was running through several circles until they found the best way to manipulate the light coming in. So at the end, they won't lose more than 5 to 6% of light, which is much, much better compared to one of the older lenses. And if you don't lose so much light, you have better contrast, then you have better vision, especially for the near, it's important, but of course also for the distance. Intermediate and distance are not so much susceptible to the amount of light coming in, but near acuity is very important. So this is a lens here, which is available, as you can see here, in a huge power range from -5 to 40. So it really covers almost anything. The near and intermediate edition is 1.5 and 3 diopters. And as I said here, you get a very good outcome in terms of light perception. They also exist in a toric version. And how they did this, when you have a diffractive system, you have different foci of first order, second order, third order, or it starts actually with 0 order. And conventional lenses, they have like at 0 order the distance, and first order, intermediate, third order the near. But you can balance that out because you have a positive and negative orders. Yeah. So what they did, they focused the intermediate emission on the 0 order, and then they used the first order as an intensifier, using the lens, the light coming in there, and applying this to the distance and the near. This way, they gained another 5 to 10% of the light. This is a trick the optical engineer can do. Yeah. And a couple of new trifocal lenses are going this way. So what you have actually is a pentafocal lens, yeah, which diverts the light towards the other 2 foci, and they balance it out very nicely. And the interesting thing is how they distribute the light in relation to the pupil size. So when we read, we have like 2 millimeters pupil. So what do we need when we read? We need the most energy here in the near focus. And this is over 50% of light energy for the near. So remember that more than 55% light energy for reading. Yeah. And when you look in the distance, and this is already after 3 or 4 millimeters, they completely change. They go down with the near light and they increase the distance light very much. Yeah. And then of course, the wider the pupil, the more the distance is necessary. And the intermediate is in that range here, also getting up to 30% of light, which is also quite interesting. And here's also the energy utilization, 6.5% they lose, compared to the other lenses on the market. It's much less, half of it. And if you compare that, for example, with Artelisa 3, we were saying here, at the peak, you need 55% for the near light. Yeah. Artelisa 3 has 1 straight line. They don't use more than 30% of the light for the near focus. Yeah, or fine vision goes with the near vision 30% also. And this is also because all the companies copy the other companies. When the first lenses came on the market, they said, oh, this is 30%, okay, we do it the same. Yeah, but you see the difference here with the fine vision. They have focused a different thing. So the wider the pupil, the more light goes to the distance. Whereas RT laser 3 is completely the same, regardless the pupil size. Yeah, but as I said, here we only use 20% for intermediate, 30% for near. Here we look 55% for near, 30% for intermediate. So it's a much better situation for the different distances. And of course, most of the light goes for the distance if you get over 3 millimeter of pupil size, similar to the others. But then you're also at the 50%, up to 60% actually here, which they reach only if you have 6 millimeter pupil dilation. So that's a quite interesting thing. We looked at this using what we call an optical bench. So in the David Apple laboratory, we have that where you look at the maximum, they call it diffraction limit, or it's the maximum quality of vision. Yeah, the so-called MTF curve is calculated. There are some ISO standards how to do that. And we compared the classical lens here, Panoptix, RT laser 3, the intensity, and also use the Technis Synergy, which is actually not a real trifocal lens. It's a bifocal lens with, it's kind of bifocal plus a symphony, yeah, combined in one lens. Yeah. And if you look at this, these are the MTF curves for 3 millimeters. That's a typical MTF curve for this kind of lenses. And as you can see, they are more or less all the same. There's almost no difference. Yeah, so the quality of the Hanita lens is as good as all the other lenses, regardless if it's Panoptix or RT laser or so. So the quality of the light is the same. If you go at higher pupil size, it's the same. Yeah, you get the same type of outcome. We can also kind of simulate a defocus curve. Yeah, and you see here that especially in the intermediate range, the intensity is much higher here at like 1 meter to 80 centimeters, much higher than all the others. Then in the near, they are pretty similar, the same. And this is when we look at the visual acuity, which is similar to the dioptic power. So it's the same kind of result with 3 millimeter pupil here. And also how they distribute it, having 3 or 2 or an elongated focus. So you see here with the intensity that you have more or less intermediate and near and kind of keep the same level. Or if you look at the so-called US Air Force pictures, you see that's a pretty good from plus 0.5 to minus 4. You can see some details. If you look at dysphotopsia, this is the same, more or less. Intensity has fairly low halo. A little bit every diffractive lens has. If you look here for intensity is pretty intense. Synergy is pretty intense in terms of side effects. Yeah, but because of the special design and intensity is less, and also RT laser and Panoptix. There's a lot of clinical work now have been done. The lens was developed in Israel actually, and let's go now to the clinical part. Yeah, so. The lens is just a normal hydrophobic acrylic. They also have a hydrophilic acrylic version. They have it as a C-loop. I'm implanting now a C-loop lens here. They also have it as a plate haptic lens. It's also available. What kind of preference you have, if you are used to like RT laser 3 or whatever, you can use the other platform. So we have a cataract removal here. We don't need to show that. And then we just implant the lens. So here you see, you just put it in the injector. This can go through 2.2 to 2.4 millimeter incision, whatever your preferences is. And then I like to deliver directly in the capsular bag. Some other people do just go in the incision and do the, but this goes in very, very smoothly. So it's nothing special if you want to implant it. It looks like any other of the lens. Just put in the other haptic and then it's quite well centered. First publication came from Ehud Assia, who actually was also at the David Apple Lab at the same time as Im Song-yong was there 20 years ago. So we know each other from that time actually. And they had a very good outcome actually. Here they did the clinical studies for the eyes. You see here the monocular intermediate visual acuity and here the binocular intermediate visual acuity. And you could see 35% were over 1.0. 75% were 1.0 and 100% were 25, so 0.8. So this is quite good. Binocular distance acuity is similar. As you can see here, uncorrected and corrected. And also near acuity was excellent. The clinical studies here, I really have to say that. They had very good defocus curve. You see here monocular and then binocular, so you get a very flat defocus curve going up here 3 diopters, as you can see. And the values for contrast and photopic and mesopic evaluation were also within the age limit. So you don't really have a loss of contrast here. And when they did this typical kind of visual function questionnaire, you can see that patients were more or less, everything was without any difficulties, all kinds of things that you do during daylight. So that's the normal thing. A little bit glare halo, but just marked as slight, yeah, which is good, which makes also sense if you look at the lens. So the outcome was quite good. There's another publication here from Argentina where they used the femtolaser assisted cataract surgery and implantation. Very similar outcome, very high degree of spectacle independence. You see here also monocular and binocular defocus curve. If you look at these patients, if they get on both sides the lenses, you always have to check the binocular outcome because this is how they run around. Yeah, if you do one eye and the other eye and each is not 100%, it doesn't matter because binocularly they usually are much better and you don't need to do any corrections. Jorge Alio has used this special protocol testing the lens. You see all the curves are the same. Yeah, so it's a very representative. You can see that very flat curve. It's not like a typical trifocal from the 5-10 years ago where they go up and then down and up and down. They have like 3 little peaks. Yeah, they usually have this kind of flat V. The only Asian studies I have seen so far was from Yutaro Nishi. He's also a former fellow from us actually. He compared synergy, fine vision, panoptics and intensity in his study. And he also had very good here binocular defocus curve, as you can see, also flat. And as you can see, the other ones were kind of going up and down, up and down. We are just now starting with, or we have started last year a study with our first patients. Some of already a 1-year follow-up. And this is in LOCMA units. So 0 is 1.0 or 20/20. And you see here uncorrected distance is 1.0, uncorrected intermediate. And near, they are all around 1.0 to 0.8 uncorrected. Corrected, of course, are a little bit better. After 1 month, and they have this defocus curve here of at least 3 diopters or 2.5 diopters. If we go at 0.2 logMAR, we get up to 3.5 diopters. After 3 months, the same. They get actually better, as you can see here. It's a typical thing that after 3 months, people adapt to a trifocal optics and they get much better than they were like the first months or the first 4 weeks when they just run out of the studies of the first treatment. The focus curves get larger, as you can see, also very flat. 6 months, even better, and similar defocus curve. And now the few we had over 12 months are also excellent. Minus 0.0 means that they're more than 1.0, and also near acuity is uncorrected 0, so 1.0. So they have all very stable outcome, grow into it, adapt to it. You see here, the focus curves becomes longer the longer they have it, which makes sense. They really adapt to it. They still see a little bit of rings, but this is on our scale fairly low amount. So if you drive at night and you see a little bit like this, you usually adapt to that quite fast. This is not really disturbing for them. That's why they judge us as slightly. If you are myopic and your glasses are not 100%, you will see even worse halo glare. So we have seen that this is a very modern lens using new approaches to distribute the light, get more out of it, more efficient than the standard lenses that we have. Very good uncorrected distance, intermediate, near acuity. Patients have a very flat defocus curve. They don't go up and down. They don't tell you a TV distance I cannot see, but further I can see. And before, some of the older trifocals have that issue. So there's 3 meters or 2.5 meters kind of blurry area, but they don't have that here. And minimal loss of light, very good neuroadaptation, and the patients are very happy. I put it actually in a couple of other doctors in my hospital because they were, I was quite confident with it. So a very, very good outcome. So if you want to ask me some questions, I'm very happy to answer anything. Thank you very much.
Can you tell us more about the pros and cons of the changing of the zero order from far to intermediate? If there is some change in glare and halo or this photojournal?
No, well, if you mean the separation of the first zero order, you mean, yeah, pushing the intermediate in the zero order. Apparently also in some other lenses gives some advantages in terms of the intensity of the halo glare, not of the occurrence. There's a difference that you can see a ring or that you can see a ring very strongly. Yeah, so and this reduces a little bit the intensity of the ring because the other foci are further away. The more distant foci from each other, the less impact they have on halo glare, on the halo size and the intensity. And if you do a pentafocal lens, you have one order in between, and this gives you some advantage on that. Slight advantage, not really an advantage where you can say this is a huge groundbreaking thing, but it's one of the little steps that improve things a little bit. Yeah? Plus more light, which gives, especially at near, a better outcome. The clinical outcome near was better than predicted on the optical bench, which was quite interesting. Yeah. But apparently it works because we saw that also in the other studies. Yeah. And the other thing is that you don't lose the energy in between the foci. Yeah. That I think is another advantage because the focus is so straight. Yeah. And I think that are the little things that help here in this context. Other questions? Yes?
Thank you for your nice lecture. At the end of the lecture, you said intensity has very good brain adaptations. Yes. Is there any reason for good?
Well, the thing is, I think if you don't have to struggle, yeah, if you have a more or less plain, continuous vision, it's easier to adapt to that as if you have some gaps in between. Yeah, if you have some gaps in between, you have to learn how to get around. Yeah, for example, old bifocal lenses took quite long to adapt. And they actually also get pretty decent defocus curves. They don't get too bad, actually. They also see something intermediate, but it takes half a year or 1 year before they see intermediate, even though they are bifocal lenses. And with this, it enables them to see quite naturally directly from the beginning. Still, there is some adaptation, you know, the lens must position, final refraction, and so on. But we have the feeling also the better light utilization allows the patient to very early adapt to it. I mean, in former times, I had to talk a lot to patients. I had to kind of pseudo-treat them with eye drops to get over the time of neuroadaptation and stuff like this. And this is not necessary nowadays. Yeah? I see them after 1 month and then after 6 months or whatever, and they don't have much issues, or they come and complain or something like this. Complaints is very, very low. I really have to say. Of course, you always have to hit the refraction good. Yeah? Every trifocal lenses are sensitive if you end up plus 0.5 or minus 1 or something like this. Yeah. But again, binocular outcome is important. If binocular they are okay, I would even leave it then.
I also worried about the contrast sensitivity at a different foci, and usually the intensity of a halo means the light contribution is high. So in that cases, during daylight, less contrast sensitivity reduced usually.
No, I wouldn't,
this is
I wouldn't say that. No, I know what you mean, but you've seen that the problem is the focus is shift too much. Yeah, and during daylight, if you have 3-4 millimeter pupil, you have a pretty normal distribution of the light. Only if you have like 2 millimeter pupil for the near, then you get a lot of energy for the near. Yeah, and but this is not the normal situation if you just walk around. Yeah. So, and I had no complaints about that. Yeah. We have to see, but maybe sometimes we think too much. Yeah. and worry too much. The patients actually will teach you very often, yeah, about some of these lenses or procedures. Okay, yeah.
Thank you, sir. And I really appreciate for your nice lecture today. And I have 2 questions. And first question is that, do you recommend this intensity lens to a person have a job with taxi driver or bus driver? And my second question is, do you have ever met the myopic shift case before? Because I have 2 patient whose myopic shift has, yes.
Yeah, I actually have one bus driver in the study who's fine, who has no problem with that. And I would, in general, I would say also modern trifocal lenses can be applied in taxi drivers or bus drivers. Yeah, I wouldn't say this is a contraindication anymore. Yeah, the old bifocal lenses maybe yes. Yeah, because it's a different design. But that trifocal balanced lens, it also depends if you have a high myopic patient who usually has some issues with contrast anyhow because of the long eyeball and the thin retina, stuff like this. But plus minus 3-4 diopters around ametropia is fine. And I think the same applies if you look at the target refraction and myopic shift. Question is, in a myopic patient, is it myopia or is it lens-related shift? Yeah. Of course, you have a higher chance in high myopics that they still have some little grow over a certain time. In our group, and we look at them, of course, 1 month, 6 months, 12 months, there was no shift. Yeah. So as you also could see, uncorrected acuity became better. Yeah. So we didn't have that. But this is a thing that you can have with any kind of lens. You have to check on the IOL calculations, to update your normograms, everything, and look at this. Company can help you on this. And then, as I said, if you have a patient with a tendency towards further myopic growth, it's a difference if you put it in a 50-year-old or in a 75-year-old. 75-year-old will not have so much shifting anymore. Yeah, but 50-year-old can have some issues. But yeah, the thing is, it will help them in the near. I think in Asian population, if they get a little bit myopic, they don't really care so much. Yeah, and in Germany, a lot of them are hyperopic, and they hate it to be myopic. Yeah, so it's a different approach. Yeah, but I think here, most of them will be okay if they end up minus 0.5. I see that also with other lenses, which are now on the market. Slight myopia is okay in Korean population. No more question? I think the one with the best question gets a bottle of champagne, don't they?
Have we tried using this intensity IOL as a mix and match?
Yeah, not yet, not yet. I know that Koreans like to do mix and match, and I think because of the technology, it would go along with other trifocal lenses. Yeah, I wouldn't think, especially then I would actually go for same platform like C-loop and C-loop, or plate haptic and plate haptic. Yeah. Otherwise, patient may see some differences and get kind of nervous. Yeah. So if you use the same platform, could be even a mix and match with other trifocals or other EDOF lenses. Yeah. When I have a patient which has like a slight amblyopia on one eye, visual acuity is not more than 0.5, but otherwise would be a good candidate. I sometimes put in the good eye the trifocal and then EDOF lens in the bad eye, just using distance and intermediate, because bad eye is not so good for near anyhow. And you can do that, yeah. So I don't think that will be an issue.
I want to ask about the complication more. Actually, for the first time the trifocal lens was introduced in Korea, always the companies saying, in glaucoma and in macular degeneration condition, and also very high order aberration of cornea, they are all contraindication for this kind of trifocal lens. So I'm just to keep that the standard until this time. But I think someday maybe we can expand these contraindications, especially for this kind of the Hanita intensity, because you showed us very good contrast sensitivity. Maybe we can overcome this kind of hold the barriers. But I'm not sure. I'm very cautious about the complaining from my patients. So what do you think? Someday we can overcome these all contraindications, or we can already overcome this contraindication?
The thing is, if we talk about glaucoma 20 years ago, that was a very dangerous disease. Nowadays, we diagnose glaucoma much earlier. We can control it long time just with eye drops. And then we have hundreds of types of surgeries to keep. This is rare that somebody, maybe with a malignant glaucoma, you get blind. But with a normal open angle glaucoma, early detected, treated, well compensated, you can go to this kind of lenses. Yeah, I'm not really worried about that. Of course, before you do that, you have to do visual field testing, and everything should be perfect. Yeah, so you just have the diagnosis of glaucoma, but you have a well-controlled glaucoma, and the wish of the patient to be spectacle independent. Yeah, so early and moderate or small type of glaucoma, I would not be so critical with it. Or you do like mix and match, put one trifocal lens, and in the other you do a monofocal plus. Yeah, then you have both. Yeah, and still patient is, so I think we can work on that. I have no issue with AMD. Yeah, I think in AMD patient, especially if it's, let's say, just an early stage or just some macular changes which are not really devastating, yeah, you can actually use that as a low vision aid, because it gives you another 3 diopter of near acuity. If you have a AMD patient, he has a multifocal lens in, and you give him a +3 lens, then he has +6 diopters. Yeah, there are studies actually showing that this is advantageous. Yeah, we're not talking about a very bad wet AMD patient. Yeah, we're talking about the normal patient who has some drusen and some little changes and is running around with that like 10 years. This also is a patient where you can go for it. And again, mix and match with a monofocal plus lens would be an option in order to make this patient, especially when they are older, more independent. Yeah, but you have to explain and counsel and tell them the specific situation. And then I think legally everything is okay. We're moving towards this already. Yeah, the company has to adhere to some liability thing. That's a different story. As a doctor, you can say, okay, in this individual patient, it makes sense. And patient was counseled and agrees to it, has signed it, then it's okay. And I think they will have more advantages of it than disadvantages. But don't put it in every patient. That's not the idea. Yeah? But in individual cases, you can do that. And I don't think it's I think they will benefit from it. Okay. And thank you very much.